glad you're here. So as folks are joining, I just want to let you know, I'm Monica Salvia, first of all, Associate Director of Alumni Engagement. And just want to say, if you'd like to turn your camera on, we welcome that. It's certainly not required, but we would love to see your faces. And we'd like to have this as a little bit of a chat. If you feel uncomfortable doing that, of course, that's completely fine. But we'd love to see you. So thank you, those of you who have turned your cameras on. Wonderful. Very happy you're here. Okay, I'll just give it one more minute. Let a couple folks get in. I know it's been a long day. And we'll get started. Okay. A couple more people entering. So I'm going to get started. So welcome. My name is Monica Salvia, and for those of you who didn't hear me say this yet, I am the Associate Director of Alumni Engagement at the University of Pennsylvania School of Nursing. And we're really excited to have you here today. I'm really excited to be continuing this conversation that we started last month. I realized it was almost exactly a month ago in follow-up to an event that the president of the university held about pandemic ethics. And we just found that there's so much, of course, to talk about in this space. We wanted to talk a little bit more about it. So we're really thrilled you're here, and we're really thrilled to have our speakers with us today. I'm going to be introducing them in a second, but of course we have Dr. Connie Ulrich and Dr. Trace Waite both here, and I will give you their bios in a moment. So like I said, feel free to turn your cameras on. We do want this to feel like an interactive conversation with all of you. So if you would like to ask a question at any point, you're welcome to do that in the chat. You're also welcome to use that raise hand function in Zoom, and that way we'll know you have something that you'd like to ask. Our speakers are going to do a little bit of an intro at the beginning, and then we'll move right into spending the bulk of our time answering your questions. They have questions for you, and we'll try to have a conversation around this. So as we get started, what I want to do is, as folks are coming in, ask to get us going here, if you would honor us by just taking a moment and introducing in the chat where you are from, and also maybe just tell us a word or two about what you think of when you think of pandemic ethics. You know, what comes to mind for you? For some of you, it may be many things. For some, there might be one particular thing that's really on your mind. If you want to drop that in the chat, that's really helpful for us to get a sense of what you're thinking about, and we'll hope to try to hit a good number of those topics as we go. And just one last announcement here, that many of you are muted right now, which is great. We'll keep the background noise down, but if you do want to ask a question at some point, feel free to unmute and do that. The raise hand function will help me know that you want to ask a question, and I can certainly call on you. But when we get to that space, you can certainly also just start talking, which is great, and add to the conversation. And I do want to let you know, which you probably see on your screen, that we are recording this, and that we will post it probably about a week after the event, so that if you missed something or if you want to share it with anyone, you can do that. And I appreciate those of you who are just letting us know in the chat there what comes to mind when you think of pandemic ethics. That's helpful, and also sharing where you are from. So right now, it's certainly my honor to introduce our two amazing speakers. First, we have Dr. Connie Ulrich, and Dr. Ulrich is the Lillian S. Bruner Chair in Medical Surgical Nursing and Professor of Bioethics and Nursing at the University of Pennsylvania School of Nursing. And she has a secondary appointment in the School of Medicine in the Department of Medical Ethics and Health Policy. She received her PhD from the University of Maryland, 2001, and her postdoctoral ethics training at the National Institutes of Health Department of Bioethics. Her program of research has focused on ethical issues in clinical practice and research. And these studies include ethical issues that providers, nurses, and social workers and advanced practitioners, as well as researchers, encounter in their clinical and research practice, and the ethical stress these issues engender. Dr. Ulrich also focuses on issues surrounding informed consent and the benefits and burdens associated with participants in cancer clinical trials. And she has such an amazing bio. I'm going to ask my colleague to put that for us in the chat so that you can read up on just some of the many things that she is working on, so you can see that there and refer to it if you would like. And it's also my privilege now to introduce Dr. Trace Waite. So Dr. Waite was with us last time. We're thrilled to have Terease here with us. She received her Bachelor's of Arts in Sociology from Yale University, her law degree from Howard University School of Law, bachelor's in nursing from Thomas Jefferson University, and in 2010, she became an alumna of Penn Nursing after receiving her master's from the University of Penn School of Nursing. And then in 2017, she graduated with a combined PhD MBE degree from the University of Pennsylvania School of Nursing and the University of Pennsylvania School of Medicine. Terease's dissertation topic was a qualitative descriptive analysis of the experiences of Blacks in cancer clinical trials. Her primary interests are bioethics, clinical ethics, and ethical and legal issues in nursing care and clinical trials. And prior to and during her doctoral studies, she worked for 15 years as an oncology nurse on Road 6 at the University of Pennsylvania Medical Health Center. Presently, she is a clinical research nurse in a lymphoma group at the Abramson Cancer Center at the University of Pennsylvania, as well as a lecturer in healthcare ethics at the University of Pennsylvania School of Nursing. So I'm just so thrilled to have both of you here. I feel really honored to have you, and I know our audience feels the same way. So what I'm going to do right now is turn it over to Connie and let you give us some introductory thoughts. I know you have a little bit of content around what these issues are and framing some of this for us. So
Sure.
Take it away.
Yeah, thank you. Thank you so much, Monica, and welcome to everyone. It's a pleasure to be here this afternoon and talk a little bit about some of the ethical concerns that I actually have, and I certainly welcome your thoughts as well. I was recently on a panel with the dean and several of my other colleagues in the School of Nursing to speak to the trustees about COVID-19 and some of the nursing concerns. And I'd like to share with you what I said to them. And I really welcome your thoughts, whether you agree with me or perhaps maybe disagree with me about what I said to them. And the dean specifically asked me about a study that I am currently conducting with clinical ethicists, some of whom are nurses, and that is funded by the Josiah Macy Jr. Foundation. And I wrote this grant because I was distressed myself in seeing some of the issues and reading about some of the issues in the media as to what was happening with my nurse colleagues. And I was trying to think of a way, how do I help my nurse colleagues? What do I need to do to help frontline workers? And I wrote this grant, and I was so thrilled to be able to be funded to try to better understand what was happening across the country with regards to frontline workers and how clinical ethicists, some of, as I said, who might be nurses, might be helping. So the dean asked me to share some of the ethical issues that we should be paying attention to during this pandemic and beyond. So my response to her and the trustees was the following. Certainly at the beginning of the pandemic, concerns about the lack of personal protective equipment and nurses struggling to care for their patients was prominent in my discussions. Some nurses resigned or asked their supervisors for early retirement. Others felt abandoned, and many were being asked to provide care without the appropriate means to do so. And they were trying to find resources wherever they could. They reused masks, for example, that created irritation and also fear of infection. Nursing positions were initially reduced, but then there were surges of COVID-19 positive patients and not enough staff to care for them. As one of my research participants told us, who was involved in the surge in New York City and who was trying to help nurses on the front lines and other clinicians, people were dying. And they were dying in ambulances, they were dying in elevators, and they were dying in emergency departments. And nurses needed help, and that help was not coming. Some told us that there was one nurse for 4 or 5 intensive care patients who were seriously ill with COVID and other complications. And their moral distress was palpable. Over and over, we heard about the moral distress of nurses and other clinicians. And sometimes this had to do with making decisions about who could visit the family. Sometimes this was about regret for not voicing concerns earlier about the patients who needed treatment and care and who were now delayed in receiving that care. Sometimes this had to do with discrimination concerns, and sometimes this had to do with the weight of just being alone with patients at their last breath. When asked what could be done, some nurses said they just didn't know how they could be helped. And they asked, what is a team anymore? Because they absolutely felt alone. Nurses also had to think about different ways to discuss very sensitive and ethically charged issues with patients and families with the use of iPads and other technology. And there were also some patients who simply did not believe that they were ill with COVID. And as you can imagine, this also placed much strain on the nurses in trying to relay information to these patients and their families. So misinformation, changing guidelines, and political discourse did not help an already dire situation. Tensions did exist because nurses didn't know who they actually could trust. One nurse manager told us that all she could do is say to the nurses on the front lines that this is the information that we have today, and hopefully we can just make it through the day. So what we need to pay attention to during this pandemic and for the long term are many, many issues. And I will just list a few here, and I certainly welcome your thoughts. First, I think we need to attend to the overall safety, health, and well-being of nurses within organizational systems, and we need to help them flourish. And we need to ask ourselves, what do organizations owe to their employees? Second, we need to focus on rebuilding trust within a system that is perceived to be broken. Third, we need to discuss using technology in the future and how this might help change the nature of our relationship with patients and families. Fourth, we need to address the future mental and physical health needs of nurses who were on the front lines and who continue to be on the front lines and who suffered with COVID themselves and who watched their colleagues and patients suffer. And fifth, we will need to think about ways to prepare nurses in the future to address the many ethical challenges that they indeed did experience. I am very proud to be a nurse bioethicist and advocate on behalf of nurses across the country and the globe, and being at Penn has helped me to do that. But never did I realize that so many ethical issues compounded within organizational and societal systems would need to be addressed and affect so many nurses across the country and the world, and whose intelligence, whose expertise and care, and I think we all agree on that, we just simply cannot do without. So I will now turn it over to my colleague, Dr. Waite, to share her thoughts, and then we can have a dialogue on all of these ethical concerns. Thank you.
Thank you, Connie. Before I begin, I'd like to say thank you very much. Thank you very much for your discussion, and also I'm so pleased to be here again. Before I start, I do have to thank the following people for the information they provided for me that I'll be presenting today. Maria Hendricks, Director of Clinical Research Operations for the Clinical Research Unit. Colleen Retlinger-Tabery, who is Associate Director of Clinical Research Operations, and Megan Blair, who is Associate Director of Regulatory Affairs. To start, to prepare for this discussion, I actually went back and looked at my emails from a year ago when the pandemic began and when the university began to close departments, labs, and to send staff home. And what really struck me was the idea that so many people were being sent home because the idea was, let's save as many as we can, let's protect as many as we can. But the opposite thought is, well, what about the people who need care? And for me, because I am a clinical research nurse, the people I consider are research participants in cancer clinical trials. So for me, pandemic ethics means possibly sacrificing the lives and causing preventable death and causing cancer deaths, which could be preventable, in order to shift and divert healthcare resources where they're more needed at the moment. So last year in March, they were needed for the care of very sick COVID-19 patients who actually came into the University of Pennsylvania Medical Center and all the other medical centers across the country. But in order to allow that, many healthcare resources were diverted. And the healthcare resources I talk about are not only healthcare workers, but also clinical space that was necessary for regular clinical operations. Clinical space, for instance, at the Perelman Center for Advanced Medicine was shifted over from clinical care to screening for COVID-19. Also, there was also a reduction in departments. Certain departments closed. Labs such as dermatology, dermatopathology, those labs closed. So for ongoing studies, we lost those resources. What's interesting is that the American Cancer Society actually has acknowledged that all of the healthcare resource diversion may actually have delayed cancer diagnoses as well as delayed cancer treatments. And this is because elective medical procedures were stopped last March. Elective surgical procedures were stopped, and essentially screening opportunities were also paused. For me, as a research nurse, it meant that clinical trials were also paused. the concern was there was so much uncertainty regarding the initial transmissibility of COVID-19 that it was deemed better to actually close certain studies. Well, not close is the wrong word, to pause studies until more was known, and the safety of patients and healthcare workers could be safeguarded. What I'm going to share with you are some slides that show the progression of the research enterprise at the clinical research unit at the Edmonton Cancer Center, and I'm going to try to share my screen. I am hoping that it works. And here we go. Can everyone see my screen? Okay.
Not yet.
Not yet. Okay, let me try it again. And can you see it now? Okay, Monica, I think I may need you.
No, sure. Yep. Ivory's
Okay.
going to pull it up for us so we can see it.
Okay.
Sorry about that, folks.
Okay. As we see here, the clinical research unit keeps incredible records of cancer clinical trial enrollments. And as we see here, there's a direct comparison between total clinical trials, which means therapeutic clinical trials, as well as non-therapeutic clinical trials, which we would call observational trials. As you can see here, the differences in enrollments from 2019 to 2020 as it stretched across the different groups in the CRU. Could you do the next slide, Monica? Here, you see the differences in the therapeutic or interventional clinical trial enrollments from 2019 to 2020. Next slide. And again here, as you can see, a better idea of how things changed from January to March. When the pandemic started, there was a slowdown in April, May, June. And then in July, the clinical research unit began a resurgence where they began to open trials again that had been paused for clinical enrollment. Just so you know, there were trials that did remain open, and those trials that remained open essentially were found to have critical need for participants or prospective participants. And actually the principal investigators who held these trials actually had to indicate the necessity. So those trials that stayed open were fit a critical need. They may have been the only means of therapeutic intervention for subjects. But as we see, starting in July, they started to open, enrollment started to increase. And can you get to the next slide, Monica?
Mm-hmm.
Here we see pretty much a breakdown of the research resurgence, which is the term that the CRU used to explain the restarting of trials. The goal originally was to return accrual numbers to 75% of pre-COVID baseline by November 1st and 100% by January 1st. However, as we see here, the goal has been reset to return accrual trials to 80% of pre-COVID baseline by April 1st and 100% by July 1st of 2021. And as you see at the bottom, over 64 trials have reopened during the research resurgence. 76 new trials have been submitted for startup, and 22 new trials have been activated. Next slide, Monica. The entire process from study pause to study resurgence to study reactivation has been an incredible effort led by so many members of the CRU. Essentially, because of COVID-19, communication was updated and refined. There were weekly, actually sometimes more than weekly updates from the CRU group regarding professional development. Remote research tools and work tools were piloted, adopted, and are being implemented and updated as we speak right now. Other changes that had to be made were coverage for real-time incidentals, such as care that was needed for patients if staff was not on site. Because as I said, the research staff was on a hybrid work schedule where we were there to see patients as our patients were there or as we needed to be there for other needs. But generally we worked from home, remoting, and we continue to do that. And as I think about the clinical pandemic ethics, I think about the fact that so much has been done, so much has been sacrificed by the research teams, by the clinical trial participants, by the outpatient and the outpatient nurses, the members of so many other healthcare workers and staff workers who remained on site during the pandemic because we had to, because we wanted to help our patients. However, again, for me, the ethical issue is the idea of protecting as many people as you could while at the same time possibly affecting the health of others. And I guess one of the questions I actually had to do with how any of you have been affected by the pandemic, by the COVID-19 pandemic, specifically in research. As a research nurse, I'm directly affected, but I'm also interested in people who are affected as participants of research studies that might have been paused and then reopened again, as well as people who are principal investigators. And I'm sure many of the alumni here are principal investigators for studies such as Connie. How have they been affected as they've tried to continue with the research enterprise? And that's it for me. And if anyone has any questions, the floor is open.
I think
Thank you for that.
I think Dr. Malise had a question for you, Terease, just about gender and ethnic differences during the pausing or continuation to clinical trials. Were there any concerns related to that?
Actually, the enrollment continued as usual, to be honest with you. So my group, which is the lymphoma group, there were concerns raised about enrollments regarding underrepresented groups. However, for my group, racial and gender differences are not an issue for us. And I don't mean not an issue. I mean, it's not something that is actually considered. How do I say this? My research is in disparities. That was my doctoral research, and I am keenly aware of disparities in terms of race, gender, and otherwise. However, in my group, lymphoma, uniformly, many of the participants are not with people of color. Gender-wise, it's pretty evenly split. But for the other groups, such as breast, prostate, lung, I cannot speak for those groups since I was not involved in those trials.
Mm-hmm. Thank you for that.
Yes.
There are a number of questions coming in. Yeah, I didn't want to cut you off.
No, I just wanted
Connie,
to say that, one of the issues that I actually have heard about, from my current interviews is this issue of moral regret, where people do feel regretful about the decisions that have been made or have not been made. And part of that might have to do with research decisions where people have been delayed, to participate in a trial, for example, or a treatment that might be necessary, a screening treatment, a colonoscopy, a mammogram, something along those lines where they were delayed in receiving treatment. And so many nurses, physicians, and others just felt moral regret because of how they might have to prioritize the needs of patients. And that's not something that we had to think about before with regards to what is actually a standard of care is now really somewhat different with regards to how we're thinking through this pandemic. So it's been very challenging for people and then feeling very morally distressed about the issues and the decisions that have been made.
I just wanted to add to, on a daily basis, I have spoken with physicians, I have spoken with research nurses who are holding on as long as they can in terms of patients who were progressing. in terms of progressing. Their cancer was progressing during the research pause, just trying to do what they could to keep the progression down or to provide the type of symptom management they needed so that trials could reopen. Now, what's important is that you know that many changes were made, many attempts to change or to modify protocols were made via discussion with the sponsors, the various sponsor discussions, hence the use of telemedicine. That was a big piece during the research, during the study pausing, and during the resurgence. The idea that not only were the staff not here, but patients also were not of it. Patients also did not come for fear of being exposed. So it's not so much that the studies were paused. Some patients actually stopped coming to visits because they were concerned about exposure. So as a result, what was important for us, in meaning the CRU, was to ramp up our telemedicine visits and ramp up other technological ways to assess our patients, to see how they were doing, to get them their needed treatments, such as the use of Penn home care and Penn home services to do previously outpatient-based treatment at home for patients, such as the idea that instead of having patients come into PCAM, we would ship their oral, for instance, the oral drugs to them. So we would see them by telemedicine, and then their drugs would be shipped directly to them instead of having them come in. So that was starting in March, and actually it still continues and is still very successful for our patients.
And I'm sure many were just very fearful. I mean, they're immunocompromised, they're very vulnerable patients, and I think just the fear of COVID-19 and the possibility of that by virtue of their travel, where they needed to go to participate in the trial most likely affected them as well. I'd like to answer one of these questions from Jane, who asked early on just about the vaccine and some of the challenges. I think she said she lives in Massachusetts and trying to deal with the eligibility and people trying to get around the rules, and those who don't have a computer skill to get an appointment. I think all of us are feeling that stress and strain, Jane. I would say every state has been absolutely different on the requirements, with regards to where they are in the process, phase 1A, 1B, 1C. I live in Maryland, so we're currently in phase 1C. And but even for me, trying to make an appointment has been so challenging to obtain the vaccine. I think, and I have computer skills, and I can probably refresh my computer, but you're absolutely right. For those who are older, perhaps do not have those, the literacy and the skills needed to be able to access, their eligibility related to the vaccine is very worrisome and troublesome. And my hope is that, we can have a broader dialogue on that in the future and think through, these many inequalities that we've seen throughout the pandemic and the many ethical challenges that people have faced and continue to face, throughout this process. It's been very difficult, even for me. I live, for example, very close to the next county, and I was not able to, and my nurse practitioner is in that county. So I assumed that I could obtain my vaccine in that county, but I was denied. I was not able to do so. So I had to scramble and try to find other places where I might be able to receive that vaccine. So it has been really frustrating, I think, for all citizens in the United States trying to figure out the best way to gain access, to this valuable resource. And I hope in the future that we can have these discussions about how we prioritize and how we make these very, very difficult ethical decisions in the future.
I wanted to answer Jennifer Costa's question. She asked the question, did you find yourself having to have participants removed due to not meeting trial requirements, labs, visits, imaging? Actually, all the efforts in the CRU were geared to prevent that. The project managers, for instance, my study team lead, Tanya Latour, was very instrumental, as were all project managers, in doing everything we could to make arrangements with, number one, the sponsors, to see if modifications could be made to the protocols, and number two, to help, and if changes could be made, to make arrangements with labs, hospitals nearby, and other facilities, so our patients could actually, well, our participants could actually have all of the study requirements completed away from our site if they could not come to our site, or if they were afraid to come to our site.
Thank you. I work in pediatric oncology as a nurse practitioner, so I'm very aware of the clinical trials, and that was one of the things we were dealing with, were families' fear of coming to the hospital, and
Sure.
that value of, meeting study requirements, but also respecting their fears and concerns.
Yes.
There were different modifications made to the protocols and timelines and stuff, so I was wondering if that was the same there as well.
Yeah.
Thank you for that.
Yeah, thank you for that.
I feel like, go ahead, there are so many, I see several issues popping up here in the chat, which I think is really helpful. And
can
ahead.
I answer
Go
Dr. Afaf's question about the moral distress?
Perfect.
Yeah, thank you, Afaf, for that question. I have been really overwhelmed. I'm still conducting the study. I'm almost finished with the study, but I've been overwhelmed by just a number of ethical issues that I've seen. Staffing issues, personal protective equipment, visitation policies, allocation of resources, scarce resources, decision fatigue, people just really worn out, moral regret, as I said. Do not resuscitate. Do you resuscitate? What are the policies? Can there be unilateral, for example, DNR, refusal of care, surrogate decision-making, transitions in care, safe transitions in care, goals of care discussions, working with marginalized populations, people who are unbefriended, whereby they have no representative to support them, just tensions and decisions between administration and what is happening on the front lines. And I had one individual say to me, how do we protect clinicians from themselves, which I thought was a really interesting statement. How do we protect them? And you're right, Afaf, it is about, that is one of the most morally distressing issues that I have heard about, is being alone with patients at the end of life, whereby, for example, a nurse would have to go into the room, Dawn and Duff go into the room, and she was the only person, or he was the only person in that room with the patient. And there would be people outside, and the nurse would have to relay the information, for example, to individuals outside, and just felt as though they were abandoned, and or they had to be very alone with the patient at their last breath, whereby they would have to use technology, an iPad or other technology, to try to relay information to family members. So yes, on a scale, I think you said of 1 to 10, I would say that would be a 10, maybe a 9 for individuals. But there are also so many other issues within that, or within the organizational systems, that also rate very highly on a moral distress scale. I most likely probably have to do another study to see where all of these issues fall out with regards to how distressing they actually have been for nurses and others within these institutions. And that I don't know yet, and I haven't fully examined all of the data. So I'm just in the process of finishing that, but my hope is that I can glean some more information from all of the data. But I certainly am overwhelmed by just all of the ethical issues that I'm seeing, and trying to think through, what does this mean for our discipline? And how do we help people in the future? I mean, I think there was a study out today that from the American Nurses Association, and I have to say, I commend the American Nurses Association, because they've really been on the pulse of trying to figure out, what's happening at the moment with regards to some of these issues. And my colleague sent me this today, where they reported that even today, 81% of nurses are just exhausted, and 65% are anxious. Many of them have emotional concerns where they're just worn out, they're stressed, they are overwhelmed. Unfortunately, I think it was only about maybe 19 to 20% said they had pride or hope. Now, that was prior to the vaccine, so perhaps that has changed. The vaccine in some ways has given us a light at the end of the tunnel. But I think we're going to have to think through and deal with many of these emotional issues that nurses have been carrying throughout this pandemic. And I'm afraid, for the long term, and what that means for us, as a discipline. So I appreciate your thoughts, Afaf, as we go forward and helping us think through these many, many challenging issues.
Yeah, and feel free to unmute if you want to, anyone, if you'd like to interact with the speakers on this, with our panelists. I feel like there are so many really important questions coming through and important topics that you've all mentioned. And there's a real heaviness to this, right? There's, we're worried, we're concerned. Just listening to both of you, Connie, as you sort of went through that litany at the beginning, I thought, yeah, that one definitely, sure. Hearing that, and then Terease, I think we had talked about this before. I, to be honest, had not considered all those issues, and it felt like one more layer of things that's out there that's not right, or that needs to be looked at. And I want to pose to both of you a little bit, and then we'll go back to some of the questions that are popping up here because they're important and I want to get to them. But how do you work through this? It feels like there's so many questions, right? There's just questions upon questions. And what is it that we do in the moment to maybe be part of the process for where we are and also going forward? How can we help address these or bring light to these or get policymakers to think about this in a way that we get in front of some of these things? What's your advice in that space?
It's really interesting. When I was doing and still doing these interviews, I became somewhat distressed myself because it was just too much. I mean, it was so in depth, and these interviews most of them lasted an hour. And what I think has helped me is that I worked with my colleague. Together, we did the interviews, working as a team. And that really helped to try to think through the issues and listen intently to what individuals were telling us, what was happening on the front lines. But I think it does make me really think through, what do we need to do in the future? And one of the questions I think from the trustees was exactly that question, Monica, about where do you take this? Can you take this to President Biden, for example? Well, he should really know, what is happening with nurses. And I think perhaps he will do that. And I think he's started to do that in some of his appointments. But I really feel like we need a commission to really look through and think through how we can develop guidelines and strategies. What do we consider, for example, to be an acceptable risk for nurses to take, in the healthcare arena when there is a pandemic? And I think that was the question that the one respondent was asking me: how do we protect clinicians from themselves? Because we take a professional oath, we take an ethical oath, and we want to care for our patients, right? Our primary commitment is to our patients, to the family, to communities, and we are trained to do that. But during a pandemic, do we have the right to say, I don't have the resources here? And even today, many individuals said, I think it was 30% or 33% said there's no planning for PPE. Even today, a year into the pandemic, we still have concerns associated with personal protective equipment. And I don't think that should be the case. So we have many discussions, I think, that we have to have as a discipline, as a professional discipline, about how we move forward. What do we consider to be an acceptable risk? Can we say no? And how do we do that? And how do we voice our concerns with regards to the many issues that we're facing?
For me, because I'm more front-facing as it applies to the public, my focus has been, what can I do for the individual people that I see, as well as for my community. What's been really important for me has been the opportunities to volunteer in my community. What's really helped, I actually live right outside of Penn. I live in West Philadelphia, University City. So what's been important for West Philadelphia is having volunteers from the University of Pennsylvania and from the nursing school go into the community. For me, what matters is more what's at the micro level. What can I do? What can I do for my patients? What can I do for my community? For instance, volunteering at the vaccine events have been held around here. Sending resources to my patients or my participants in the clinical trials I'm with about what they can do about COVID-19. In fact, 2 of my participants did develop COVID-19 while they were receiving chemo. So for me, it was important for me to support them the best I could, which for them meant giving them information, tell them where to go to get information, being available for them whenever they need me, which was a lot. But actually, I felt very gratified knowing I was able to help them and their families, as all of them actually experienced the COVID-19 experience. Also, what was important to me too was the resources that were actually afforded by the University of Pennsylvania for healthcare workers like me, who are front-facing, such as Cobalt. which
Mhm.
actually was so amazing for me and for other healthcare workers who needed to have that support when we actually experienced mental distress from being actually with people, talking to people, sharing their experiences, but still having our own personal issues regarding the workplace balance, family issues. For instance, my father died in November, not related to COVID-19. However, during the time I couldn't visit him, I had a lot of problems with that. I couldn't visit him in Florida because of that. So I relied on Cobalt. It was really important for me. But going back to some of the issues that Connie talked about, I mean, I have to say, and I am digressing, one of the things that I think people are not considering, and though it has come up, is the idea for people who are in ICUs or intensive care unit, other intensive care units who do not have COVID-19, but who may feel that they're being rushed out of the ICUs to make way for COVID-19 patients. And unfortunately, that was my father. Ultimately, he did pass within 10 days, but as someone who has cared for people in hospice and palliative care, who has been involved in surrogate decision making, I strongly feel and I truly believe that my father was being rushed out of the intensive care because they wanted more room. So for me, what was important was knowing as someone who knows the ethics of palliative care and hospice. Do I tell the physicians who are caring for my father, stop trying to rush him out of the ICU? Okay. And I wonder if other nurses have felt that. I mean, to have to hear the discussions and participate in discussions, knowing that a family member is being rushed out to make way for someone else. I mean, that's something that I think, as Connie said, causes emotional distress for the nurses and emotional distress for nurses who are family members who have patients in the hospital.
Yeah, I don't think we've touched on as much of the distress that family members, have faced. But even though I have heard it through my interviews, especially, for those, who are working through end of life issues with their loved one. And I think that's something in the future, again, that we really have to think through, and the moral distress that family members have faced, during this pandemic, through isolation, through masking, through being away from their loved ones, through trying to talk through computer systems, to their loved ones, and being afar. It's really interesting, when I ask about the use of technology during COVID, most of my respondents have said it's either really positive, they find it to be positive, or it's really challenging, and some are really in the middle, it's neutral. In many ways, it takes away from the relational aspect that we all are trained and know about, with regards to our nursing discipline. There's something about me putting my hand on your shoulder, Terease, and saying, or maybe not saying anything, but putting my hand on your shoulder and saying, I understand, your issues today, or I'm so sorry about your father. There's something to that, that being close in that way that I think is lost, through the technology. And also we as a discipline are going to have to think about, what are the benefits and burdens of using that technology and remaining with patients and their families and having that sort of relational aspect of care. And perhaps we've lost that a little bit, with regards to COVID.
There's a note that's come in from Lisa related to that. I'm sorry, go ahead, Terease.
Oh, I'm sorry.
Or was someone speaking up?
Lisa's, I agree with Lisa's comment, and I thank you, Lisa, very much. I've heard that too. I think nurses, yes, you're right. They were called heroes. People were clapping, and that's all wonderful. But I think there's more value to nurses than that. And my hope is, through some of my work and my advocacy and discussions, that the public will see nurses in a different light, and how much they have contributed during this pandemic. And I am an advocate for hazard pay, so I think I might start to write about that. Try to get nurses hazard pay for the many risks that they have, taken during this pandemic, and to see their value within the organizational systems. In many ways, I said previously to some of my colleagues, I think that, to heal, and we have to heal, from this pandemic, that we might have to forgive some of the organizational harms that have come to nurses, within the system. But that doesn't mean we have to forget And that does not mean that we should not hold them accountable for the harms that have occurred to nurses with regards to not having PPE and other resources that they needed. And nurses, I think, have lost trust, in many ways. Someone said to me, one of my respondents said to me, they were talking about vaccinations and starting a vaccination program within the institution. And the nurse said to this particular individual about, look, you placed me on the front lines, you put me at risk, and now you're asking me to be one of the first people to take this vaccine? No. So somehow we have to build that trust back within those organizational systems where nurses, a large majority of nurses work, and show their value within those organizational systems, however we define that. I think we need to define that for the public and for legislators and just for the societal good.
That's a great way of saying that. Thank you. I want to switch gears slightly. There's a more specific question in here from Karen. We're thinking about outside of, maybe not totally outside of the clinical space, but thinking about education, nurse educators, and they're faced with trying to orchestrate student experiences and at the same time, meeting clinical agency needs. And I know that for the School of Nursing at Penn, of course, and I'm sure at most, if not all institutions, that's been a real challenge. The up and coming clinicians need experience, and they need to be on the floors. And how is that prioritized in the space while there's fears for their safety? There are rules about how many people can be in a space at one time. And so I'm going to turn to you, Terease, if you have some thoughts on that from being on the clinical side, and Connie, if you want to add some thoughts to that as well. What are you seeing? What kind of issues come up for you when you think about that?
Well, as a lecturer in the healthcare ethics course at Penn, I actually talk to my students all the time about some of the issues that arise. Actually, they are amazingly open and honest, and actually say they feel they're getting the experience they need, but they would like more. They don't feel unsafe. They're testing like twice a week. They've all been vaccinated, but one of the issues they have is what can they do to affect change where they are? That's some of the issues. They ask very intellectually challenging questions about their clinical experience, questions that I think could be answered if they had more time on the floor. They're talking about ethical issues regarding circuit decision-making, about the care they can provide as student nurses, being mindful that they are student nurses. And amazingly, they're also talking about legal issues, about liabilities, those type of liabilities and duties and responsibilities that they actually are thinking about nurses. On the clinical side, all I would say is that they need more. They need more time on the floor. And I'm sure they need more nurse educators who are willing to go on the floor with them. But of course, a lot of this is constrained by actually policies that are there to protect them. So all we can do, and all they say is hopefully in the spring, strike that, hopefully in the fall, they'll be able to have more time. And I think that's what the nursing school is working towards.
Yeah, I would add to that too. First of all, I have to thank Dr. Melise, because she advocated for a nurse bioethicist to be in a school of nursing, to help train nurses. So she really was very much in the forefront of thinking through the importance of having a nurse in a school of nursing. And I think that I also teach a bioethics course for nurses. And I think it's critical. Of course, I'm biased in saying that, but I do think, after we've seen what has happened in the pandemic, and I know, there's just been so many challenges for them. And I think we have to be a bit protective of them as well. They are vulnerable in many ways, so we have to balance, how we protect them within that clinical arena and what we expose them to, but also in an effort to train them for the reality. And there's often sort of a disconnect between, that theoretical perspective that we teach them and also what they actually see in clinical practice. So part of my goal in teaching, and in the bioethics course is to help to present. And I've presented some of these realistic, issues that have been occurring within the healthcare setting and allow them an opportunity to express their thoughts and address the issues and challenges and the fears and the anxieties that they might have, so that once they get into that clinical arena, at least they have had an opportunity to think through, those particular issues. It is interesting, through the ANA, I think it was 30%, maybe around 30% of nurses just did not feel prepared. And of course, we might argue that, yes, indeed, how could they have been prepared for a pandemic? But there were issues about safety and other concerns and resources that are discussions that can happen, with bioethicists to help them think through those many issues. And I know Mary Walton for years, worked at the hospital, and she was a wonderful asset to nurses there and allowed some nurses to train or follow her through the process to see some of the ethical issues in the clinical setting. And that was very, very beneficial to nurses as well. So I think we're making strides, but we still have a lot of work to do. And, as I said, I think students are vulnerable in many ways. It's a hierarchical system, within the clinical arena, and we have to protect them, but also, as I said, help them learn and train and help them think through, the many challenges that they might face and see.
Yeah, and I do want to add one more thing. As a result of one of my lectures, I was able to touch bases with Eliza Narva, who actually is the director of the ethics committee for the University of the Pennsylvania Medical Center, and we actually talked about setting up a subtype of a support blog for nursing students who have ethical issues. Mm-hmm. Which is something that I will continue talking to Eliza about, because many of them do say they have ethical questions that they feel that if they could be supported would be really helpful for them. In fact, both the two sections for healthcare ethics overwhelmingly said they would be interested. So that's something that hopefully will be coming in the fall.
It is very unfortunate to me that, about 45% of nurses in a survey that was conducted said that they did not feel supported, within organizational systems. And, most organizational systems have clinical ethicists within those systems, but nurses don't always feel comfortable or confident in accessing those services. And there's a variety of reasons for that. So I think through education, part of the goal of bioethics education is to help nurses have a voice and to share their voice and to recognize that they, just like any other member of the healthcare team, can access a service, if they need it, an ethicist, if they have an ethical concern, that they can use their voice, to share their concern for the good of the patient.
Thank you. I think we might have time for one last question. I'm sure there are so many issues that we haven't touched on yet, but if folks have anything, if you want to jump in, or feel free to post a question. And also, if you have an anonymous question, that is completely acceptable too. Feel free to send that to me directly, and I'm happy to read that. If you're not comfortable stating it out loud, I wouldn't put your name. So.
Yeah.
Just wrote
yes.
a general question.
Hi, Afaf.
Hello. Thank you both for the compassion and the kind of questions you are asking that are really important. And I'm really sorry about your father, Dr. Waite, and what you went through. So this is, and I wrote it there, this is not the first pandemic, nor the first epidemic we have gone through. And I just think that the systemic racism that we are just beginning to address now has been with us for so long. Epidemics have been with us for so long. I think this is organizational systemic neglect, not to be prepared for it. So this is really troubling me. Why did the nurses have to go through this when we knew long ago, and we have gone through that before? What is wrong organizationally that we don't address these very fundamental issues and questions that create so much havoc for nurses and for healthcare providers? Mm-hmm. So any comments as to why?
I absolutely agree with you, Afaf, on every point. I think it's organizational neglect too. And it's really fascinating to listen to the interviews. It really stems around these organizational ethics types of issues. I have to think about your question. I'm not sure what the issues actually are unless I say, is it the bottom line, so to speak, the profit margin, within the organization. So if you think about, elective surgeries were stopped and then they furloughed nurses. And nurses were the people that they actually needed when the surge happened, and they didn't have the nurses to care for the patients. And then they brought in nurses that were travel who made a higher rate than the people who were actually loyal to the institution. So to me, that's neglect too, in many ways. So I think that we have to think through these issues very substantively and thoughtfully and think about what do we expect of organizations? I've been thinking about it from an engineering perspective because my husband's an engineer. And I think your husband is an engineer too, Afaf. And thinking about that, yes, they use this term called factors of safety. What is the load, so to speak, before something will break? And they factor in these factors of safety. And I've been thinking about that from an organizational perspective. What do we need to think about? What are the factors of safety? We need to have an appropriate number of nurses, staffing. We need to have those resources that you indicated, Afaf, within those systems of care. And maybe that's something that we can argue for, that we need to develop these, and these need to be in place before we have another pandemic, which we know, as you said, most likely will occur.
Mm-hmm. I was, Dr. Melise, I guess what strikes me is not perhaps, but definitely, I think nursing has been undervalued as a resource in the research enterprise, in the clinical enterprise, however you want to look at it. We've been totally undervalued. I look about the time when nurses, not for this pandemic, but when there are other issues that arose economically, nurses would be let go. Or would be asked to retire. I remember that in the mid-90s when I was looking for a job and you couldn't find a job. But the bottom line is what you miss is the infrastructure of nurse leaders. That's what we miss when, as you say, organizational neglect occurs. I mean, if there is no infrastructure for nurse leaders, how do we empower nursing students? How do we empower new nurses? How do we empower nurse educators to set up and feel empowered to implement the type of structures that we need, instead of acting as quote unquote worker ants? We need to be working as leaders at every level, not just at the research level, the clinical level, the academic level. I think we need to make ourselves heard. I think nursing became a little complacent, just a little, but I think now we're at a point where we should actually make our voices heard in all areas of nursing, in all areas of technology, in all areas of healthcare facilities. Just looking at what's happening now, for instance, where I am, nurses feel very powerful. We feel that we can ask for changes and expect changes. The question is are we going to continue this once the pandemic wanes? I mean, are we going to ride the tide and just do what we need to do, or are we just going to become complacent again? And I don't mean to be pessimistic, and heaven knows I don't have as many years in nursing as you, Dr. Melise, and you, Connie, but I'd like to think that we'll keep doing what we need to do now, using the pandemic as a springboard.
My worry is the same. My worry is that we'll go back to baseline and not address these issues, that we've been facing. And that's just simply unacceptable to me at this point. I mean, after everything that I've heard and seen, and I think your term organizational neglect is the correct term. How do we move forward? And we have to use our voice to do that, and other means, through our writings, through our work, to try to get that out there to the public and also to the larger society, legislators as well.
Thank you. I feel like that is a great way to think about next steps here in the future and what our role needs to be. Those who are in healthcare, those who care about those in healthcare, and those who care, frankly, about inequality and ethics and our neighbors and our community. So I really want to say thank you to all of you for being here today. I know we always want to come to these kinds of conversations, with what's the answer? What's the answer to everything? And the answer is not always easy, but it's something we're working on together. And I think having these discussions is really powerful, and caring about these things is really important. So thank you all. Specifically, of course, I have to thank our amazing speakers and experts, Dr. Ulrich.
Thank you.
Yep. And thank you, Dr. Waite, your expertise, your voice, the space that you've given us to talk about this and to think about this. and just sit with that discomfort sometimes is really important. So I appreciate that. And I just want to say thank you to all of our folks, our attendees who were here today. So it was lovely to see some of your faces, to see your names, and to have you participate. If I just want to say from alumni perspective, if there are other conversations or topics, or if you want to continue this topic, please just let me know. We're happy to be responsive to what you need in this space. We certainly want to come alongside and be supportive. And I think the idea of advocating is something we're going to take a look at and seeing how we can provide some of that space and continue to do that together as an organization. So have a wonderful evening.
Thank you.
We are going to be sending out a quick survey just so you can give us some feedback, but thank you for being here, and we'll let you know about some of these other events coming up. It was a pleasure, as
Thank
always.
you.
So
Thank you
everyone,
very much.
take care.
Thank you.
Bye-bye.
Bye-bye.